A very good day, my dear postgraduate students. The topic for the day is on the screen: autopsy and gross, ureter and bladder. Now, we all must be wondering why such a topic has been chosen. It is, of course, for the sake of completion. Tomorrow, if you do get an assembled autopsy and there is one such bladder, there are 10 of you facing the exam. Imagine the questions that could be asked. So also structures such as the ureter, which means we cannot afford to omit anything. At the same time, we need not know too much about everything. With this small introduction, I go to the topic proper. The ureter itself. You are seeing a fine line diagram on your right. It has a length of about 30 centimeters and a width of about 0.5 centimeters. There can be various strictures. Definitely, whenever a structure crosses it, there can be a stricture. The uretropelvic junction, interposition of the blood vessels, entry into the bladder. So these are all some points of stricture which we should bear in mind. They are normally present, or sometimes there can be external pressure leading to a partial or a complete obstruction. So these are the couple of ureters, and you find that the ureteric orifice is quite low down. The bladder is a dome-like structure, and there will be the urinary bladder, the ureteric orifice, and a sphincter. The intervening area is the urethra. These we shall be having in mind. Now, there are certain structures which we will have to remember. It is almost retroperitoneal, and it has got a relation to the seminal vesicles, the vas deferens and the bladder. Also, there is a lower part of the broad ligament that is opposing it. Obviously, a picture like this will give us things better. This is a sagittal section, which I like very much. I'm going to restrict myself only to the bladder. However, there should be a clear idea. Now, in the case of a male, which I shall be showing again, this is the rectum over here and this is the vesicle. So there is a rectovesical pouch over here. Also note that from the testis, there is a vas deferens which circumvents the bladder and goes up to the seminal vesicle. A triangular organ of the prostate is there in the region of the trigone of the bladder, or rather the neck of the bladder. The penis and other things we people. The seminal vesicle is another important organ which is usually missed and even not thought of at a reporting. So these things we people shall be having in mind. What are the structures which are adjoining behind it and which are entering the seminal vesicles? This is a female counterpart of the one. The earlier picture was a male, which means there is an interposing uterus and the cervix as such, the vaginal canal. You find that literally he says that the uterus lies over the bladder. See this one, you find that the uterus is literally lying over the bladder. Any of the pictures you people can choose. And this is more colorful. In this case, there is a uterorectal pouch that is over there. Also, there can be a utero-vesical pouch. These are two areas which should be looked for when a grossing is being done or when the surgeon is going to search for some extension of a tumor. The urethra is over here, and I think the rest of it is clear. This white region is the symphysis pubis. It is a bone. So this is the female counterpart. The earlier picture was the male. Obviously, if you people are asked the differences or even otherwise, it will be meaningful to know the differences. Courtesy allow me for this picture. Now, what are the diseases we should think of? Normally, in any organ or even a surgery or a differential diagnosis, you people are supposed to think of the anatomical, the congenital, the inflammatory, the neoplastic, the tumor-like lesions, and so on. Here also, I find that there can be congenital anomalies. Some I shall be showing. There can be inflammation, which can be specific or non-specific. There can be infection secondary to a transplantation. Obviously, there can be a rejection, there can be a death, the body can land up for autopsy. Obstruction, fistula, ureteritis cystica, ligation. So, these are certain things which we will have to look for. As I told you, there can be some congenital anomalies. This particular class is restricted to the ureter and the bladder. So shall I. So, in one case, there has been an obstruction and then there is a hydroureter. There is a distension. Now, when such a thing is kept for you people, you should know the differential diagnosis of distension. Hydronephrosis is definitely a specimen to be kept. And you will also be finding a megaureter or a distended ureter, which can be unilateral or bilateral. It can be because of congenital defects such as phimosis, posterior urethral valve. Also, enlarged organs such as the prostate, any of the lymph node outside, pregnancy, any structure that is, which we call as kinking of the ureter, can lead to a distension. And from within, there can be the stones or there can be a tumor, persistent inflammation. All of this can be leading to a hydroureter. So always have a list of this with you. It is not difficult at all, but we should not be appearing blank before the examiner at the exam. Also, there are a couple of other congenital anomalies. Sometimes there can be an ectopic testis, and from the ectopic testis, there will be another ureter. So there is a duplication. There is also another condition wherein I find that there can be see what is happening. A dysplastic kidney, and there can be a duplex ureter. So these things we people should be having in mind. Any of it have at least a couple of it for your references. What are the causes for congenital obstructions? What can be the congenital anomalies? What is the duplication? When it comes to the kidney, there are many things. Hope I'll be able to cover it in some class, including the horseshoe kidney. Now coming to the bladder, what is the anatomy as such? So this is the anterior view of the bladder. There is a ureter that is entering it. This is a ureteric orifice, and between the urethra and the ureteric orifices, there is a thickened area which is called the trigone of the bladder, which should be inspected for any malignancy. Also, there is a uvula of the bladder and the urethra that is shown over here. What is important over here is now where is the base of the bladder? The base of the bladder is the posterior surface. It literally lies on it. and there is a superior surface and an inferior surface. We should be having these in mind so that the anatomical position can be at least imagined. As I told you earlier, there can be a rectovesical pouch, a utrovesical pouch. And the inferior surface, which is more anterior, is supported by fat. Internally, you have got this. And circumventing the urethra in the case of a male will be the prostate. And in this region, there can be a dome-like elevation, which is called the verumentanum. So, such structures we should have in mind. Please do not disown it because it is important and mug up only the opening of the heart. On the superior surface, sometimes we can find an obliterated urachus. This is not too very important at autopsy, but then at diagnosis, you might find an adenocarcinoma. An adenocarcinoma is less than 1% in the incidence of bladder cancer. But then, where does it arise from? It is from the persistent urachus. Similarly, we can find obliterated umbilical arteries. Now, what do you people do? When a patient or a body has been brought, one thing that we will have to do is to rule out an infection. It can be an infective cause, and one thing that we will have to obtain will be the urine. The urine that has been retained will have to be drawn by a sterile syringe and subject to biochemical as well as microbiological investigations. They say about 50 ml is drawn. There is another method by which you find that whenever there is going to be an obstruction in the urethra, the bladder will have to be opened up under sterile conditions and then the contents obtained. We are not supposed to probe the urethra. The urethra is somewhere lower down. It is not supposed to be probed and then the urine obtained because it can dislodge an obstruction or it can mutilate a tumor. And when the urine is obtained, sometimes it can be cloudy. It does not mean it is infection. It can be because of the phosphate or the urate crystals or sometimes the desquamated epithelial cells. So again, please observe there is a symphysis over here, there is a bowel, there is a rectum posteriorly, and there is a female, so there is a uterus and a cervix, and there are the various pouches that are present. This explains clearly how the opening is being done. So this is a normal structure. So ureter is entering it and it is being partly covered by the peritoneum, which is being reflected over it. And in the case of opening up, what is done is there is a blunt probe through the urethra and then it is cut. The prostate is cut open and the urethra is also slit open. We go into the bladder. The normal capacity of the bladder is about 200 to 300 ml. But in some cases, extreme hypertrophy can lead to diminution in the contents. And my professor of urology used to say, in such a case, the bladder is not able to carry out its function and a cystectomy can be done. Again, the catheterization. We are not going into the details of it. There can be the catheterization which is not uncommon in urology. But this can be a cause for an infection or sometimes a persistent pool. Definitely you people are going to get a specimen of a pyelonephritis. And pyelonephritis, what are the causes of infections? There is a class of mind based on Robbins and in which you will be finding the ascending infection and the descending infections. In the ascending infections, one of the causes that is given is a retained catheter. There are many other causes. Your Robbins gives more than 14 to 15 causes for pyelonephritis, kindly go back and read. And what will happen? Normally, it is a balloon-like structure. In fact, you can get a real balloon, which I might show in one of the pictures. But whenever there is going to be a slow and a persistent obstruction, as in the case of a prostatic hypertrophy, you find that there will be a thickening of the bladder wall. And I'm finding bands of these fibromuscular tissue traversing it in all directions, which is natural. So there can be a hypertrophy of the bladder. And in some cases, there can be an inflammation of the bladder. The inflammation of the bladder, the cystitis, we should be bearing in mind. One of the most common causes of cystitis can be cystoscopy, or it can be catheterization, or it can be any of the cystoscopes being introduced, suprapubic, etc. So there can be an introduction of an infection. The infection itself, it can be appearing quite hemorrhagic, and the hemorrhage can be because of the trauma that has been induced. Also, there are two types of these infections. One is an acute inflammation, second one is chronic. Acute, it can be many of it, and the appearance, it appears as purulent and hemorrhagic. Kindly have it in mind. There are various polyps or tumors. Whenever we talk about the tumor, there can be a polyp, there can be a transitional type of a carcinoma, there can be a metastatic carcinoma. These three things alone we people can be remembering pertaining to autopsy. I am not talking about the classification of the bladder tumors. And look at this one. Naturally, this is not a bladder epithelium, but then it is just pushing inside. It can be mistaken for a bladder, which is incidentally a case of a diverticulum. And a tumor here. You find it is almost occupying the entire bladder, and there can be obstruction of both the ureters leading to a bilateral hydronephrosis. The gross description is very obvious. You find that it has got a papillary configuration. It will be friable, and whenever there is a bladder filled with urine, you find that these papillary processes will be moving around like sea anemones in sea. Here again, I can see that there is a hypertrophy of the bladder. Look at this one, very delicate papillary fronts. It can be unicentric, it can be multicentric. One can be a primary or it can be the secondary. So these things you people should be having in mind. Be bold enough to answer. I cannot rule out at this stage whether it is a primary or a secondary or a multicentric lesion. Also, I find that there can be calculi. So this is a beautiful case of, look at the thickness. This itself is thick, and look at the thickness over here. The rugosity is well maintained, and then the thickening of the bladder wall. And there is a prostatic hyperplasia over here. And within the retained urine, I can find calculi developing. If you go back to my class, renal calculi is one of the classes, and I would like you very much to kindly read it up thoroughly. Coming to the bladder tumor. So you find that it arises, and this is a beautiful picture for the staging of the bladder tumors. Starting from, it can be in situ up to a completely invasive tumor, which is going either into the bone or into the prostate or into the surrounding pouches. So kindly go through this one. You people are well versed with it. And what should be important is sometimes, because of the anatomy, there can be the vaginal bladder or cystic fistula that can be formed. And when there is such a tumor, I do not know where the origin of it is. Not infrequently, we face such problems. there are poorly differentiated papillary tumors. Even in one case we had recently confronted, there was a poor differentiation. The tumor was totally detached from the rest of the ovary and the fallopian tube, and we could not place. And to make the situation more complicated, the patient was having multiple peritoneal metastasis and a lung shaft. So this is one that people should be having in mind. When such a specimen is there, is it originating from the vagina or from the bladder? We had seen a case of acute cystitis. Again, it's over here. So it can be, or sometimes it can be a chronic cystitis. In this case, it is quite necrotizing. Necrotizing cystitis is not uncommon, particularly in patients with diabetes, then a pyelonephritis, and so on. And also in patients with persistent obstruction. There is an entity called an inflammatory pseudotumor. There can be areas of thickening or yellowish white plaque-like thickenings. And one of the differentials that we should be having in mind will be malakoplakia, which itself is a university question for you. So there can be a necrotizing cystitis, an acute cystitis, a chronic cystitis, a hemorrhagic cystitis. The hemorrhage, these are the causes, the probe and the catheterization. This is an important one right from the theory point of view. So I find on one side, this is a picture that we people should remember. So this is the bladder wall, this is a ureter that is entering it. So it is more theoretical, but it is very important in the case of a pyelonephritis. There is something called as a ascending infection, and this is the lumen of the bladder. What happens will be when a person is voiding urine, there is a compression of these muscles, as a result of which this ureter becomes closed, and hence the urine passes out of the ureter. But in some cases, when it is too very, perpendicular, then there will be no complete obstruction, and hence there will be a compression of the muscle everywhere, and the urine will tend to go into the ureter as well, the urethra. So this leads to what is called as an ascending infection. So this is an important one which you people will have to explain in your question on pyelonephritis. In this case, there is again a distension that is seen, which is called a vesicocele, or the ureterocele. From the ureter, there is a distension. If it is going to be from the bladder, we call it a vesicocele. And these can be demonstrated by means of voiding cystograms. Again, the same story. I find that there is a mega ureter over here, and there has been two. So it is a duplication of a ureter that is seen over here. And in this case, it is more obvious. There can be an obstructive ureterocele that is seen over here. So what happens is you find that there is a mega ureter or a hydroureter. What will be the cause? You'll have to mention. And there are different grades for it. I would like you people to kindly go back to it. Is there a grading system? You just say yes. And when it is going to be extended into the kidney, look at this. It is quite difficult to say that it is a kidney and a hydronephrosis. It looks almost like a parchment or a membrane. There is a total distension with atrophy of all the parenchyma, and there is a total destruction of the pelvic ileal system that is seen. In PhD Medical College in Coimbatore, there used to be a very large balloon-like specimen of the hydronephrosis. And if you go near it, it will appear as though it is about to burst. And these are again cases of megaureter, in which there is a distension that could be seen. And look at this one. it can be getting attached to the rectum as well. Now, what else can you see in the bladder? The calculi. A professor of mine in the undergraduate classes used to hide this calculus with a thumb of his, show the X-ray, and we will not be able to find anything. Removing the thumb, we see a huge calculus that is obstructing the ureteric or the urethral orifice. So, definitely in your specimens, be it the kidney or the ureter or the bladder, there can be a calculus. This also is again a bladder calculus. They can be quite large because there can be a growth by accretion that is possible. Whereas within the ureter, it is extremely painful and the calculi will be small. So also in the urethra. So far, what all have we seen? What is the structure of the ureter? What can be the congenital anomalies? What are the causes for vesico-ureteric reflux? And what can be the various causes for the obstructions? In the bladder, what is the normal anatomy again? What is the relationship to the rectum and the uterus? What is the anterior surface? What is the base? What is the trigone of the bladder? Also, we have seen the acute cystitis, the chronic cystitis, the differential diagnosis of malakoplakia, and the bladder cancer. The staging of the bladder cancer. So, I would like you people to kindly go back to the corresponding classes and reinforce, because one such specimen is kept for us in the exam, the questions can go in any direction. I won't be surprised if one gets a battery of questions on hydronephrosis and another student on the renal calculus. So kindly correlate with your theory, and my classes can be continued because we have got the seminal vesicle, the prostate, and the testis. Thank you.